Conventionally, bundle of his originating from lower part of the AV node divides into left and right bundle branches. Left bundle branch further divides into left anterior and left posterior fascicles. The existence of an additional left septal fascicle has been demonstrated in multiple studies, but for simplicity's sake, only the left anterior and posterior fascicles will be considered in this discussion. Left anterior fascicle is a thin fascicle with single blood supply. Hence, it is affected far more commonly than the left posterior fascicle, which is thicker and has dual blood supply. But if the left posterior fascicle is affected, that usually carries a poorer prognosis due to the more extensive disease process causing it. Right bundle branch block is characterized by an RSR prime pattern with the R prime being slurred, producing a QRS duration of 120 milliseconds or more. This delayed right ventricular activation is reflected as a delayed and slurred S wave in leads oriented to the left ventricle with lead 1, AVL, V5 and V6. The same pattern, if it occurs with a QRS duration of less than 120 milliseconds, it is generally designated as incomplete right bundle branch block. Mild ST segment depression and inverted T waves in anterior leads are associated with RBBB. Unlike left bundle branch block, which often coexists with structural heart disease, RBBB can occur in the absence of structural heart disease. RBBB may complicate acute myocardial infarction of the anterior wall, in which case it has prognostic significance, usually indicative of more extensive myocardial infarction and possibility of left ventricular dysfunction. Incomplete right bundle branch block pattern can occur in atrial septal defect, Epstein's anomaly of the tricuspid valve, and acute pulmonary embolism. ECG showing right bundle branch block with RSR prime pattern in V1 and slurred S waves in 1, AVL, V5 and V6. QRS duration is 120 milliseconds. Shallow T inversion is noted in anterior leads. ECG showing incomplete right bundle branch block with RSR prime pattern in V1, V2. QRS duration is only 100 milliseconds. PR interval is 200 milliseconds. T-wave inversion in anterior leads can be associated with a conduction abnormality. It could also be due to persistent juvenile pattern in young individuals. Left anterior hemiblock is diagnosed when there is left axis deviation in the absence of any other causes. It manifests in the ECG with RS complexes in inferior leads and QR complexes in 1 and AVL. It is the commonest type of fascicular block and carries no additional prognostic significance. It may increase the QRS width up to 40 milliseconds, but seldom does it cause a true wide QRS by itself. LAHB can occur in the setting of anterowall myocardial infarction and in congenital heart diseases like ostium primum atrial septal defect. LAHB is more common than LPHB because anterior fascicle is thin and has only a single blood supply from the left anterior descending coronary artery. Hence, it is quite common with anterowall myocardial infarction. But prognostically, it is better than LPHB because its presence does not indicate extensive myocardial damage in the setting of anterowall myocardial infarction, as it can be damaged even with a smaller extent of myocardial infarction than the posterior fascicle. Left posterior hemiblock is rare and has ominous prognostic significance unlike left anterior hemiblock. This is because it has dual blood supply and hence damage would be more severe if it has been involved. When it occurs in the setting of anterowall myocardial infarction, it indicates extensive myocardial damage and is usually associated with significant left ventricular dysfunction. When right bundle branch block is associated with either left anterior or left posterior hemiblock, it is known as bifascicular block. Trifascicular block is the forerunner of infrahisian complete heart block. When bifascicular block is associated with PR interval prolongation or second degree AV block, it is known as trifascicular block. Alternating left and right bundle branch blocks also qualify for the term trifascicular block as it indicates damage to all the three conduction fascicles. ECG demonstrating trifascicular block. RR interval is 1800 milliseconds and PP interval is 900 milliseconds, suggesting 2:1 AV conduction. There are small Q waves in lateral leads. Slurred S waves are seen in lead 1 and AVL, and RR pattern is seen in V1, suggesting right bundle branch block. 2:1 AV conduction in the presence of RBBB suggests that conduction in the left vesicles is delayed and blocked. Overall, this constitutes one type of trifascicular block. This can also be considered as Mobitz type 2 second-degree AV block. This type of block has a higher probability of progressing to complete heart block and producing Stokes-Adam attacks. Mobitz type 2 second-degree AV block is due to disease of the conduction system below the level of the bundle of His and hence is called infrahisian block. When infrahisian block progresses to complete heart block, the subsidiary pacemaker which takes over is usually idioventricular rhythm, which is intrinsically slower and unstable, leading to episodes of ventricular asystole causing Stokes-Adam attacks. Sometimes ventricular tachyarrhythmias in the form of toss at the point can also occur in the setting of complete heart block. ECG showing bifascicular block manifested as right bundle branch block with left anterior hemiblock. Slurred S waves in lateral leads and slurred R waves in V1 are suggestive of right bundle branch block. The initial R wave is missing in V1 and V2, possibly due to an old anterior wall myocardial infarction. Left axis deviation with RS pattern in inferior leads and QR pattern in AVL suggests associated left anterior hemiblock. The QRS width is increased as part of the complete right bundle branch block pattern. T-wave inversion in V1 to V3 could be due to right bundle branch block or previous anterior wall myocardial infarction. PR interval is 200 milliseconds, indicating that it is moving on to a trifascicular block. ECG showing RBBB with LPHB and anterior wall myocardial infarction. Right bundle branch block is evident as wide QRS 160 milliseconds, slurred S wave in lead 1 and slurred R wave in V1. In V1, there is QR pattern suggesting anterior wall infarction with right bundle branch block, QRBBB. The QRS shows right axis deviation, dominant negative deflection in leads 1 and AVL, with dominant positive deflections in AVF, along with RS pattern in lead 1 and QR pattern in leads 3 and AVF, suggesting left posterior hemiblock. The PR interval is borderline at 200 milliseconds. If PR interval is prolonged in this combination, it becomes trifascicular block. Left posterior hemiblock is the rarest of the fascicular blocks as it is spared in most cases due to dual blood supply. For the same reason, left posterior hemiblock carries a poorer prognosis. Since the left posterior fascicle is a broad fascicle compared to the anterior fascicle and has dual blood supply, it is involved only in more extensive myocardial infarction. This would mean more severe left ventricular dysfunction. The combination of left posterior hemiblock with RBBB carries a still worse outcome. The very wide QRS for an RBBB in this case also indicates more extensive myocardial damage. The T-wave inversion in leads V1 to V3 could be explained either by the old myocardial infarction or by the right bundle branch block. When right bundle branch block is associated with extreme axis deviation, that is QRS axis in the right upper quadrant or northwest axis, it is difficult to say whether it is extreme right axis deviation or extreme left axis deviation. Some authors have used vector cardiography techniques to determine whether it is extreme left or right axis deviation, but these are quite cumbersome for routine use and has not gained popularity. This ECG shows RSR prime pattern in V1, RS pattern in 1 and AVL and V6, all features of right bundle branch block. The amplitude of R waves in lateral leads are quite low. QRS width is a little more than 120 milliseconds. The QRS axis is in the northwest region, right upper quadrant, which can mean either extreme right axis or extreme left axis deviation. RS pattern is seen both in inferior leads and lateral leads. Hence, it is rather difficult to say whether it is left anterior hemiblock or left posterior hemiblock which is associated with the RBBB. PR interval is normal. QRS pattern in chest leads show a clockwise rotation with S waves persisting up to V6. The slurred R prime in V1 and slurred S in lateral leads suggest delayed activation of the right ventricular myocardium, which proceeds by conduction through the myocardium rather than through the specialized conduction system of the heart. When the conduction through the left bundle is delayed or blocked, a characteristic pattern is seen on the ECG, which is known as the left bundle branch block. Though LBBB is often associated with structural heart disease unlike RBBB, LBBB can also occur in isolation without any structural heart disease. The initial left to right septal activation is lost in LBBB. Hence, the initial R in V1 and the initial Q in lateral leads are absent in LBBB. QRS duration is increased above 120 milliseconds. It has an M-shaped pattern in lateral leads and a W-shaped pattern in anterior leads. Cabrera sign is a notching in the ascending limb of the S wave in V3 or V4, which is 0.04 seconds. Chapman sign is a notching more than or equal to 0.05 second in the ascending limb of the R wave in lead 1 AVL or V6. Both are taken as features of myocardial infarction in the presence of LBBB. ECG showing LBBB with first degree AV block. Left bundle branch block with first degree AV block is a type of trifascicular block, since the PR interprolongation could indicate that the conduction in the right bundle is also affected. Rarely it could be due to a coexistent conduction delay in the AV node rather than in the infrahisian conduction system. LBBB with first degree AV block may be considered as a forerunner of complete AV block. First degree AV block in this ECG is manifest as the prolonged PR interval of 280 milliseconds. LBBB is manifest as broad notched QRS complexes in lead 1 and AVL. The poor progression of R waves and wide QS complexes in anterior leads are also consistent with LBBB. But V6 is not showing a wide notched predominantly positive QRS complex. This disparity between V6 and lead 1 are often seen when the QRS axis is leftward in LBBB. Inferior and anterior leads are showing a pseudo infarction pattern which is common with LBBB. ECG showing left bundle branch block with myocardial infarction. Cabrera's sign is seen as a notch in the ascending limb of S wave in V3 of 40 milliseconds. Chapman's sign is seen as a notch in the ascending limb of the R wave in leads 1 AVL and V6 of 50 milliseconds or more. This ECG also shows a PR interval of 0.2 seconds. Sharp P waves in lead 2 suggesting right atrial overload and prominent negative P waves in V1 suggesting left atrial overload.